Which of the following parameters is expected to decrease as a direct result of properly timed IABP counterpulsation? A. Mean coronary perfusion pressure. B. Left ventricular end diastolic pressure, LVEDP. C. Cardiac output. D. Cerebral blood flow. Answer: B. Left ventricular end diastolic pressure, LVEDP. Explanation: by creating a vacuum effect just before systole, presystolic drop in afterload, the left ventricle empties much more efficiently. This leads to a decrease in left ventricular end diastolic volume and a subsequent decrease in left ventricular end diastolic pressure, LVEDP, relieving pulmonary congestion. An arterial pressure waveform showing an inflation wave that occurs well after the dicrotic notch, resulting in a distinct visual valley between the notch and the rise of the balloon pressure, represents which timing error? A. Early inflation. B. Late inflation. C. Early deflation. D. Late deflation. Answer: B. Late inflation. Explanation: late inflation occurs when the balloon inflates significantly after the aortic valve has closed. Because of this delay, the suboptimal pressure wave fails to provide maximum diastolic augmentation, reducing the potential benefit to coronary artery perfusion. When evaluating an IABP waveform, you notice that the augmented diastolic pressure drops sharply to a baseline level long before the next R wave occurs. What is the primary physiological consequence of this early deflation error? A. Structural damage to the aortic valve. B. A severe increase in systolic afterload. C. Loss of vacuum-assisted afterload reduction. D. Retrograde coronary blood flow. Answer: C. Loss of vacuum-assisted afterload reduction. Explanation: if the balloon deflates too early during diastole, the vacuum effect is lost by the time the left ventricle actually begins to contract. As a result, the patient loses the benefit of afterload reduction, and coronary perfusion during late diastole is compromised because the pressure drops back down prematurely. Beyond valvular disease, which of the following conditions represents an absolute contraindication to inserting an IABP? A. Severe peripheral vascular disease. B. Known descending thoracic or abdominal aortic aneurysm. C. History of mechanical mitral valve replacement. D. Mild carotid artery stenosis. Answer: B. Known descending thoracic or abdominal aortic aneurysm. Explanation: the presence of an aortic aneurysm, thoracic or abdominal, is an absolute contraindication due to the high risk of aortic rupture or dissection caused by the mechanical pulsations and pressure shifts exerted by the balloon against a weakened aortic wall. If an IABP balloon ruptures and blood enters the balloon envelope, the helium can cause the blood to clot inside the balloon. What is the immediate risk associated with this complication during removal? A. Systemic gas embolism. B. Entrapment of the balloon inside the artery. C. Acute right ventricular failure. D. Pseudoaneurysm at the insertion site. Answer: B. Entrapment of the balloon inside the artery. Explanation: when blood mixes with helium gas inside a ruptured balloon, it can solidify into a large clot. This creates a hard bulb that cannot be deflated or pulled back through the arterial sheath, leading to balloon entrapment. This typically requires surgical cut-down or open vascular repair to extract safely. A patient on 1 IABP support develops sinus tachycardia, with their heart rate increasing from 80 bpm to 135 bpm. What adjustment must the clinician expect from a properly functioning, modern auto-timing IABP console? A. Diastole shortens, so the console must shorten the balloon inflation duration. B. Systole shortens, so the console must prolong the balloon inflation duration. C. The console will automatically switch to a 1:2 assist ratio to compensate. D. The console will switch to internal asynchronous mode. Answer: A. Diastole shortens, so the console must shorten the balloon inflation duration. Explanation: as the heart rate increases, the cardiac cycle shortens primarily at the expense of diastole. Therefore, the balloon inflation time must shorten to avoid inflating into the next systole, which would cause a dangerous late deflation error. Modern consoles automatically adapt their timing algorithms to handle these rate shifts. A patient with an IABP suddenly develops ventricular fibrillation, VF. The IABP console sounds an alarm stating no trigger and stops pumping. What is the correct immediate action regarding the pump? A. Switch the console trigger to pressure mode. B. Switch the console trigger to internal mode at 80 BPM while performing CPR. C. Turn the console off completely until the patient is defibrillated. D. Increase the balloon volume inflation manually. Answer, B. Switch the console trigger to internal mode at 80 BPM while performing CPR. Explanation: during cardiac arrest, like VF, there is no organized ECG signal or arterial pressure pulse to act as a trigger. To prevent blood from stagnating and clotting on the static balloon during resuscitation, the console should be switched to internal, asynchronous, mode. This keeps the balloon moving at a fixed rate, which can also provide minor circulatory assistance during chest compressions. When selecting an IABP catheter size for an adult patient, which physical characteristic dictates the appropriate balloon volume, e.g., 34 cubic centimeters, 40 cubic centimeters, or 50 cubic centimeters? A. The patient's weight. B. The patient's height. C. The baseline mean arterial pressure. D. The diameter of the femoral artery. Answer, B. The patient's height. Explanation: balloon sizing is based on the patient's height because height correlates directly with the length of the thoracic aorta. Selecting a balloon that is too long for a short patient can result in the tip obstructing the left subclavian artery or the base obstructing the renal arteries. Daily laboratory monitoring for a patient supported by an IABP reveals a steady, significant drop in platelet count without evidence of heparin-induced thrombocytopenia, HIT. What is the mechanism behind this finding? A. Helium gas directly destroys circulating platelets. B. Mechanical shearing and entrapment of platelets against the balloon surface. C. Bone marrow suppression caused by aortic counterpulsation. D. Splenic sequestration triggered by altered diastolic flow. Answer, B. Mechanical shearing and entrapment of platelets against the balloon surface. Explanation: thrombocytopenia is a well-documented mechanical complication of IABP support. The continuous, rapid inflation and deflation of the balloon damages and shears platelets as they pass through the descending aorta, leading to a consumptive mechanical thrombocytopenia. Which of the following scenarios presents a relative contraindication where an IABP can still be placed if the benefits outweigh the risks? A. Moderate to severe aortic dissection. B. Severe calcific peripheral artery disease, PAD, affecting both iliofemoral systems. C. Severe aortic valve insufficiency. D. A mobile thrombus in the ascending aorta. Answer, B. Severe calcific peripheral artery disease, PAD, affecting both iliofemoral systems. Explanation: severe peripheral artery disease, PAD, is a relative contraindication. It makes insertion technically difficult and increases the risk of limb ischemia or arterial perforation, but if the patient is in profound cardiogenic shock, alternative access, e.g., axillary insertion, or careful ultrasound-guided femoral entry may be attempted. The other options are absolute contraindications. What is the primary operational advantage of using a modern fiber optic IABP catheter over a traditional fluid-filled lumen catheter? A. It allows for the transmission of oxygen saturation data. B. It eliminates the need for an ECG signal entirely. C. It provides instantaneous, crisp arterial pressure waveforms without dampening artifacts. D. It permits the use of ambient air instead of helium. Answer, C. It provides instantaneous, crisp arterial pressure waveforms without dampening artifacts. Explanation: traditional catheters rely on a fluid-filled central lumen connected to a transducer, which is prone to waveform dampening, whipping, or delay. Fiber optic catheters use light sensors at the tip to transmit the pressure wave at the speed of light, providing an immediate, highly accurate arterial waveform for precise timing calibration. In the context of the cardiac catheterization lab, which patient profile represents an appropriate indication for prophylactic IABP insertion? A. A patient with a normal ejection fraction undergoing a single-vessel routine stent placement. B. A patient with severe left main coronary artery stenosis and depressed LV function undergoing complex PCI. C. A patient presenting with an active ischemic stroke. D. A patient with severe chronic renal failure awaiting a fistulogram. Answer: B. A patient with severe left main coronary artery stenosis and depressed LV function undergoing complex PCI. Explanation: prophylactic, preventative. IABP placement is commonly utilized for high-risk percutaneous coronary interventions, PCI, such as severe left main disease or last remaining conduit vessels in patients with a very low ejection fraction. The balloon acts as a safety net to maintain coronary perfusion during temporary balloon inflations or transient arrhythmias during the procedure. Aside from a standard chest X-ray, which bedside imaging modality can be rapidly utilized in the intensive care unit to verify the correct positioning of the IABP balloon tip. A. Transthoracic or transesophageal echocardiography. B. Focused assessment with sonography for trauma, FAST, scan. C. Continuous abdominal fluoroscopy. D. Computed tomography, CT, of the chest. Answer: A. Transthoracic or transesophageal echocardiography. Explanation: echocardiography, especially transesophageal, or TE, in the operating room/ICU, can visualize the descending thoracic aorta to verify that the balloon tip is properly positioned just below the takeoff of the left subclavian artery. Transthoracic views can sometimes identify the tip via the suprasternal notch window. While weaning a patient from an IABP by decreasing the assist ratio from 1 to 1 to 1 to 2, which clinical development indicates that the patient is failing the weaning trial. A. A decrease in heart rate from 95 bpm to 80 bpm. B. An increase in urine output. C. A rise in pulmonary artery occlusion pressure, PAOP, along with new chest pain. D. A widening of the pulse pressure with stable mean arterial pressure. Answer: C. A rise in pulmonary artery occlusion pressure, PAOP, along with new chest pain. Explanation: signs of weaning failure indicate that the left ventricle cannot handle the return of its baseline afterload workload. A rise in PAOP, indicating rising left atrial/ventricular filling pressures, recurrence of angina, chest pain, downtrending blood pressure, or worsening ventricular arrhythmias mean the patient still requires the mechanical support of the 1-to-1 ratio. During an inter-hospital transfer of a patient on an IABP via ambulance, the helium tank on the console runs empty. What happens to the device? A. The console will automatically switch to drawing ambient air to inflate the balloon. B. The balloon will fail to inflate, the console will alarm, and counterpulsation will stop. C. The balloon will remain locked in a permanently inflated state to preserve pressure. D. The console will function normally but at half the assist ratio. Answer: B. The balloon will fail to inflate, the console will alarm, and counterpulsation will stop. Explanation: an IABP cannot operate without its gas source. If the helium tank runs empty, the console cannot inflate or deflate the balloon. It will trigger a critical alarm and stop pumping. Transport teams must always confirm that backup helium tanks are full before initiating a patient transfer.